I'll kind of blow through that. If you go to my LinkedIn profile, there's links to more depth on that particular topic. But let's go ahead and dive in. Appreciate the opportunity. I think for a reason I put in the center of the universe there is the patient, and I think it's very important. Certainly every organization wants to say they're patient-centric, has for some time. What I'm going to get into is a lot more about why that's not just a marketing catchphrase anymore. It's a matter of life or death, not just from a clinical perspective, but really from a business perspective. So I'll get into that, and certainly a big part of that is going to be breaking down silos. As Mark mentioned, I thought I'd just touch on a little bit of my background. Every speaker, every individual comes in with their biases, and we're all kind of describing the elephant with blindfolds on sometimes, so you can see what mine are. So I started my career in Accenture, implementing health IT systems in basically a couple dozen different hospitals. Went over to Microsoft as they were getting in the enterprise. Main reason I share those two experiences, having implemented or reviewed a lot of systems, I thought about, gosh, what's the purpose of a patient from at least a health IT perspective? And really, a patient needs to be there because you need to have a vessel to pour billing codes into. That's really what those systems have been architected to do, and it's a very logical, rational response to the historic reimbursement environment we've been in. Obviously, that's changing. I did a long detour away from healthcare. It's where I got to know Chris a little bit when I was detouring into digital media, and then I came back into healthcare about 5 years ago. And I've always liked doing startups, even inside of a big company like Microsoft started their healthcare vertical market, which is about a $2 billion a year business today. And I like those early stage startups. The reason after I left Microsoft about a dozen years ago, I didn't do healthcare. I said, healthcare is where tech startups go to die, was always my mantra. I didn't want to work in a startup that died, so I stayed away. But a handful of years ago, obviously there's a lot of chaos and turmoil that's been introduced into the market. And really a startup is a bet on how the future is going to unfold and get there just a little bit ahead of where the market is. And so I felt like the best way to do customer discovery and find where those gaps were was to do writing. Short of Obama, I could pretty much speak to anybody. And it was a great way to understand where those gaps were. I kind of knew the general direction I was headed, but it helped hone in, and ultimately got very focused in on patient engagement, which led to being asked by HIMSS to co-write first book on patient engagement, which was great. It won the book of the year. And the most important thing, though, was getting a lot of insights into the leading organizations and what they were doing. Also was on Oliver Wyman's, still am, on their Health Innovation Center advisory board, which is made up of senior execs from really every sector of healthcare. And they kind of crowdsourced from this group projections as to where the industry is going to go, which I'm going to reference later. And then I did start Avado. We believe we're the first company to be founded as a patient relationship management company. You hear that term a lot now, but that's what we did. Really it was about bringing the patient into as a full member of the care team, and we were acquired by WebMD a couple years ago. I left there about 2 months ago, so I'm fully unshackled. No corporate overlords on my presentation here, so hopefully that will be a benefit to you. But a fundamental belief I had was that the solutions are out there. Putting aside, clinical breakthroughs, finding the cure for cancer, and so on. I believe the structural fixes are there. However, for most people, healthcare is indecipherable as Egyptian hieroglyphics. So I have this Rosetta Stone metaphor, and found as I started to pull on this string, not only had found some pockets of breakthrough performance that really, I think, gives you a lens into where things are going. I found this employer called Rosen Hotels and Resorts in Florida, and just really breathtaking results, taking a fresh look. A couple decades ago, they basically said, this is messed up how things are going. We're going to kind of opt out of the regular system that's not really delivering value. And a number of amazing outcomes, starting with they pay 50 cents on the dollar compared to a typical employer. With great outcomes, they have above average age employee base, about 3,000 or 4,000 employees. They have quite a few people who've come into the country with diseases we don't tend to treat. So they didn't have an easy base there, and really a great benefits package. And then what they've done, and this is what's really impressive, is they've harvested the money that hasn't been wasted in healthcare and turned it back into a number of great things. For example, all of their employees, after they've been there a little while, they will pay for their education, college education. They take that a step further. They will pay for their dependents' college education. And then they take that a step further because they're not wasting this money. And over the course of the time, they believe they've saved about $240 million versus their peer set. The founder basically adopted a crime-ridden neighborhood near their headquarters and started with funding pre-K and daycare, and then basically followed these kids through their to and through college. And basically over the course of that time, total investment about $11 million, which is about what they save each year versus their peer set. And so they've taken the crime rate. There's been some other programs too, but this has been a big part of it. Crime rate in that community went down 63%. The high school graduation rate was at 45%. It's basically at 100%. Now the college graduation rate is above the national average from a community that really didn't have great results there. And he's not even stopping there. He's now adopted a community that's 5 times the size of that, because there's so much amazing things you can do if you don't waste money. And you know, that's really a big part of it. And you know, those of us who've been in the marketing industry certainly know the Wanamaker problem. You know you're wasting half your ad dollars. You just don't know which half. Fortunately, digital has gotten rid of a lot of that. But that was certainly pervasive for the last 7,500 years. Well, healthcare's got its Wanamaker problem too. PwC and others have data that basically half the dollars we spend don't add value. And that's pretty horrendous given the dollars that we spend. More importantly, I think back to the people I went to school with. Generally the smartest kids went into medicine. Many of the most passionate, caring people I know went into medicine. I think in a lot of ways we've sort of stripped humanity out of these people with the way the system works. And a lot of this is about restoring humanity into healthcare. One of the things I alluded to earlier was Oliver Wyman. They wrote this paper released a couple years ago, The Volume to Value Revolution. You've probably heard those terms, basically making the case that in this country, of the $3 trillion that we spend, roughly $1 trillion is going to shift from one set of players to another over the next 10 years. Huge winners and losers. So you can lean back, play defense, or you can lean in and play offense. I love we know there's a lot of uncertainty. I like this quote from Colin Powell. It's really about there's a certain information available to you when you're going to make a business decision, or really any decision. And his point is, gather at least 40%. If you don't gather that, you're probably just making seat of the pants decisions. But if you wait until you have 70% or more, you're going to miss the opportunity. It's really in that 40 to 70 spot. And I would argue we're here. And organizations are sitting back, whether it's complacency or deer in the headlights, whatever, that's going to be a big issue. And I see things that aren't just concepts, but are potential events that are being discussed or actually done, just not at scale yet, that certainly people in New York understand the notion of black swan events. Any one of these, I believe, could radically accelerate that disruption. So I'll go through a few from my vantage point. The whole way we handle aging and end of life is a great book Atul Gawande came out with recently called Being Mortal that got into that a lot. There was a Wall Street Journal article a few years ago, basically said, why doctors die differently. They're well aware of the limits of what medicine can do. And if you take and mimic what's happened in La Crosse, Wisconsin, where 96% of the population has an advanced directive and it's honored by the healthcare system. With Medicare data, they're spending 40% less there. Or you look at places like Denmark, where they've really shifted from the majority of people dying in a hospital to where most people want to spend the end of their life is in home. They want to be warm, dry, pain-free, and with loved ones. That's really what it boils down to. And we can, again, do a lot better. I think Wande's book did a terrific job of kind of laying out a prescription there. Another thing that I'm seeing more and more is unions who now are often responsible for, in these labor management negotiations, a lot of times management pushed a big pot of money across the table to unions and said, now it's your problem. And if they don't address it, there's not going to be retirement money for these organizations. And then mid-market businesses starting to flex their muscle. In part, there's this looming Cadillac tax that's really, after today's ruling from the Supreme Court, kind of the last big thing that potentially, there's some talk of repealing the Cadillac tax. I personally am one that says bring it on. Because I think it's going to force a level of creativity that's good for disruptors. But you see where, like the Rosen case, where it could really, lead to people spending money smarter. It could be reduced utilization. I'll talk about some high performers later, and I think it's relevant to this audience. You see where they have overachieved. It's interesting. 2 areas where they increase spend and increased utilization and effectiveness is primary care and medication adherence. Every other thing goes down in these high-performing systems. So I think it's worth noting, particularly with this group. And then you see in a place like where Rosen is headquartered, other businesses are going, gosh, I want some of that. They're very frustrated with the healthcare system, and they see somebody else has actually done it in their community, and they're following that up. And so I think that could be a potential another one. Again, you look at almost every system I've seen that's really providing breakthrough results on the quadruple aim. Probably many of you have heard the triple aim. I like the quadruple aim. It needs to work for clinicians too. We sometimes forget that because we're just layering a bunch of more stuff on top of docs, and the rest of the clinical team, leading to really high rates of burnout and dissatisfaction. But you see compression of revenue may cause the bond. I believe there's a strong revenue bond bubble. We've funded hospital growth to the rate of about twice what experts say is the number of beds we need in a given community. Every health system CEO I've ever talked to has said, yeah, there's at least a 40% overcapacity. Of course, they believe they'll be the ones last man standing. But it's well known. That ripple effect could hit other sectors. So I think it's important to be mindful of that. If you've been following any budgeting, local, state, federal level, immense pressure. All these things are being talked about. Economic Development 2.0, it's really playing the healthcare card. The old model was put a marketing veneer around your community, throw some tax breaks at some company to relocate. Those tax breaks get washed away by far by whether you're a high value or low value healthcare community. Companies like IBM choosing, okay, we're going to put a few thousand people in Dubuque, Iowa, because it turns out their value proposition is as good as the Japan or Netherlands on a per capita basis. School board and unions really rethinking this. I actually am having interesting outside of the whole labor negotiations. I'm having the head of the school board, superintendent, and teachers union over to my house on Monday. Kind of talk about, really, you've been fighting each other. You're putting fingers in the dike. If you look at the data there, it's really pretty frightening what's happened in terms of healthcare basically eating away at school funding. They're putting fingers in the dike, and if they take a look over the dike, they'll see a tsunami coming that you just can't sort of, work your way around it unless you really rethink it. States, some are talking about changing the tax-exempt status of hospitals, to balance budgets. Attorneys may disrupt some of the anti-compete agreements, which could potentially really harm some of the innovation. And at the federal level, everything from, I don't know if this will ever happen, but Medicare being allowed to negotiate with pharma or using reference-based pricing in Medicare, all those things would have a lot of pressure on the community. Or citizens fighting back. The number one cause of bankruptcy and homelessness, I'm told, as well, and the fact that people have almost no retirement accounts is healthcare. I wrote a piece about this on the fact that if you were 52 years old and worked for the last 30 years, and if healthcare inflation had grown with inflation for everything else, which obviously didn't, it went like this, medical inflation went like this. To my knowledge, our lifespans haven't doubled. And you invested that spread, the average household in an S&P index fund, let's say, the average American household would have about $1 million in their retirement account. So it's very significant. So anything from class action lawsuits, given the number of avoidable deaths, to one of the things that I'm actually a documentary. Healthcare is really, there's been the let's throw the industry under the bus sort of documentary that Michael Moore did, but I'm talking about a documentary that would actually be, give people, yes, cause to pay attention, but it really, hey, there's a solution here. And something like that, we really have not had an Inconvenient Truth-like documentary to raise the public consciousness. A lot of people don't connect the dots with what healthcare spending has done to not only education but infrastructure and things like that, and the data is really stark on that. So a number of things certainly should get your attention. Most of us have really operated in the benefits-based economy. It's a significant economy. That's the one we've operated in. But we know the interests of individual patients are not really aligned with the healthcare systems. That's on the negative side. On the positive side, it's a known business model, so there's some advantages there. And certainly providers and health plans have figured that out. But I think it's important to recognize there's this other big economy that's the consumer discretionary spend economy. I actually participated in an event with Novartis and the COPD Foundation a few weeks ago. It was very interesting. Brought a bunch of people from inside and outside the healthcare arena to really take a step back and how can we, it's very much a beyond the pill, but way beyond the pill and beyond even traditional healthcare. How can we help impact people suffering from COPD? And though there were technology people there, and quite a few, a lot of the most compelling solutions really would fall into this bottom half of this slide in terms of consumer direct opportunities, and that market is sizable. It has some advantages in terms of its consumer centricity. It does have some disadvantages in terms of it kind of puts the individual in the place of a systems integrator, because these things are very disconnected. I think with that, there's a lot of opportunities. We certainly know about the rise of consumer-driven healthcare and population health, but really there's going to be new platforms and services, and we heard one example earlier, really the connective tissue for this disruption. And so that's a second economy that's a big opportunity. And the third one was mentioned a little bit in terms of health. The traditional clinical care only addresses 10 to 20% of the outcomes. There's all these other things that were referenced earlier that you can go up and down these, and there's digital health companies to be had, either have already been created or will be created. And the key thing here is, and part of my detour away from healthcare, spent a fair amount of time in the local media arena, and I'll tell you, the words I hear today coming out of healthcare organization executives' mouths are basically exactly the same words I heard out of newspaper executives' mouths in sort of the late 90s. And they tended to discount a lot of things. And if you look at all the things that they could have invested in, acquired, partnered with, probably represent about 80% of the digital media revenue, which is far bigger than the newspaper industry ever was. But that kind of blinder on thinking kept them from doing that, because they really had that zero-sum game mentality. And I think it is obviously critical to look beyond that. A good example of this, one of my favorite business stories is how Southwest Airlines didn't look to other airlines, but they looked to NASCAR pit crews for one of the things that gave them one of the biggest competitive advantages, which was gate turnaround time. And that's been a big part of why they're the only airline that's consistently made money. So now let's borrow a lesson from aviation. If you know anything about aviation industry, not only does an airline say, yeah, I'm going to buy from Airbus or Boeing, but often an independent decision is they say, am I going to get a engine from, say, GE or Rolls-Royce? So in the case of Rolls-Royce, they have this total care program, and today they're getting over 50% of their revenues in this new model. It used to be, say, American Airlines would specify, okay, we're going to buy a Rolls engine. Rolls would get a bunch of money, maybe a little aftermarket revenue, but that was basically their way. And what they do today is very different. They get paid based on the number of hours that the engine is functioning in the air. So very, very different. Now it's over half their revenue. Think about a device company that would think, that would have a business model that way. Why shouldn't they? What it's really done is aligned interests like they weren't aligned before. And certainly we know about the need for aligned interests in our industry. It's apropos, given all the big data talk earlier, that they are now really excelling in their use of data with all kinds of telematics to get data and really understand what's going on so that maybe they can see some issue arising before it actually happens. And really from the very core design, they're designing service in from the get-go versus an after the fact. So I think it's a good example. You bring that back into healthcare. It's not hard to imagine care traffic controllers. In fact, not everybody's using that term, but some of the leading organizations are actually doing that, like CareMore, where people with congestive heart failure are sent home with wireless remote scales. And like in this example, in contrast to, actually I'll do a little sidebar story. One of the advisors for my startup, this guy named Ted Epperly, past president of the American Academy of Family Physicians, he took me on a tour of his clinic one time, and we got to the waiting room and he said, this is a failure. We're just sitting here waiting with catcher's mitts for people to present themselves. We should think more like NASA Mission Control or something like this, where we're really proactively identifying people. Obviously, that's a lot about what population health is all about. And so, here, it's monitoring, Mrs. Greenberg, and, before she may know there's an issue, intervening, get her on Skype, call her in. In the case of CareMore, if she doesn't have transportation, they send a car out to her. They'll readily spend $500 or $600 to avoid a $30,000 event because they're in a Medicare Advantage program, capitated. Again, that's where most of these models are shifting. So these things can be done, and the capabilities need to, of course, get more sophisticated. If there's only one slide that you remember and pay attention to, it would be this one. This was the biggest aha moment for me. From this Dr. Doug Eby. He is Chief Medical Officer for the South Central Foundation in South Central Alaska. They can check all the difficult boxes. They were once a failing Indian Health Service organization. They had substance abuse issues. They had diabetes issues. All kinds of issues, and their 50,000 patients were spread across 1,500 miles. But they took a very different approach. And the key thing was they looked at what's driving outcomes. They really obviously wanted to have an impact on outcomes, and then say, who are the outcomes? And certainly in a high acuity scenario, the professionals, the system makes most of the decisions that drive outcomes, and that's very appropriate. I certainly don't want to weigh in on, my heart surgery. I don't have any value to add there. And he draws this analogy with, like a good athlete, let's say a baseball pitcher. You can train them to throw a ball at a target, and they're going to hit it the vast majority of the time. That's what a procedural, well-trained surgeon is all about. And again, a lot of what health systems have done about, borrowed from the manufacturing arena. But then this is where it gets interesting, where the vast majority of the dollars are spent, 75–80%, it's around chronic disease. It's actually not the professionals who make most of the decisions that drive outcomes. It's the patient, the family, the caregiver. All kinds of other factors, as he says, the messy human stuff comes in. Do they fill prescriptions, complete them, take them appropriately? Diet, exercise, lifestyle, all these other things really come into the mix. And they wanted to get out of the excuse business, and they got into those messy human issues and understood what was going on. And that's what's led them to be a Baldrige winner and have phenomenal outcomes. It was not an overnight thing, of course. But he said there, unlike that pitcher throwing the ball at the target, it's a lot more like throwing a bird at a target. There's a lot of other factors that go in. Is the bird's baby over at the target? Is there a predator between here and there? There's a lot of other factors that weigh in. It's not just, throw it out there. And so that's really, really critical. If you're going to make a difference on outcomes, this is a big part of why I said earlier at the outset, patient centricity is not a nice to have. It used to be from a bottom line standpoint, but as everything's being shifted to more of an outcomes-based model, if you don't figure that out, you're going to fail. And more and more national health systems are going that way, payers are going that way, and that's really where the game is going to be won or lost. And this is a quote you've probably heard before: "The future is here, it's just unevenly distributed." Healthcare is all about that. As I mentioned earlier, the solutions are out there, they're proven, there's evidence, there's some modest scale. Still a small fraction of the overall market. But if those were actually brought together into one place, and Rosen's probably the one who's come closest to doing that, there's some pretty amazing things that can happen. And some example of, one of my favorite quotes is Buckminster Fuller's. You can't change things by fighting the existing reality. You got to create a new model that makes the old one obsolete. And this is an example of a lot of interesting things going on, from new primary care models to, remote monitoring and lab testing, telehealth, digital therapeutics. There's a lot of activity in the genomics area. There was one of the real rock stars of the biotech world, Lee Hood. If you were following the news real closely, in the last week they announced sort of a new primary care model. They're really going to combine sort of the insights from his P4 medicine that he's worked on with a primary care model that's not, they've had kind of a pilot of basically rich people who've gone in that, but they want to make this available very broadly. And I'll brag about my hometown, Seattle. It's really been a source of strength in terms of primary care. The #1 med school for primary care is there. Concierge medicine was invented there. Direct primary care, which is kind of concierge medicine for the masses, was invented there, and now this one. And so there's some interesting things going on. And really what it amounts to is essentially a shadow healthcare system. Just like there was kind of a shadowed, media environment that was ignored by a lot of the incumbent players. And we've seen what's happened over the last decade or so. That's happening. Again, it's easy to not see because it's not by anywhere near the majority, but it's definitely happening. And so I like this kind of Rosetta metaphor. You think about when you're a new employee or you're a new Medicare or Medicaid recipient, you essentially get this kind of stack of healthcare services, health and wellness services you get access to. Going back to that Wanamaker issue, basically that's a radically underperforming stack. If only 50% adds value, that's not great. So really the question is, what up and down that? So this is something as an open source project that I'm trying to catalyze, like, hey, this should be common knowledge. What are these proven elements? And you think about it, this is, nobody loves you more than your mom, right? So this is the health plan that your mother would design for you that actually worked. And I was thinking about names for it. You could call it Yo Mama Care. But that might confuse people with another model. So I went with Health Rosetta as that. And people can take, they can use Yo Mama Care if they want. But it really does make a big difference. I'll highlight a few areas. I've certainly a huge believer. Maybe I'm a contrarian. A lot of people say, oh, primary care is dying. Well, I hope the milk in the back of the store model of primary care is dying. And that's really the byproduct of what we've done is we've marginalized primary care to where they're on a hamster wheel and what can they do and if they want to make money in 7-minute appointments other than be the milk of the back of the store to push you to high margin activities. These high performers, these are a couple articles I wrote. You could get more detail. The hot spotters, that have really done a terrific job. This is not theory. There's strong evidence there. And I saw some of these organizations with my own eyes, CareMore being one, IR Health's another good example. And gosh, I was in there and my parents are getting up there and I was like, gosh, I wish I could get my parents into one of these. Not that they've got a bad doctor, but really the way I look at kind of the primary care system and for somebody like my parents is they're kind of in a boat, rowing it around, and when, they're in a safe harbor, it's okay. I could kind of help, they could navigate it. But the reality is, in the case of my dad, he was diagnosed with Parkinson's about 6 months ago. The seas are going to get choppy. They're not that bad right now. They're going to get really rough. You want a seasoned sea captain when it gets rough. And most people are just going to get tossed around without that. And that's unfortunately what happens. I mean, I'm sure if I went through this room, I bet at least half the room has got some pretty horrible story about what the system has done. I mean, in fact, Gwande in his book, both his parents are doctors. Between the three of them, they had 120 years of medical practice and things got out of control for them. And so in some respects, what a great primary care system is doing is really being that sea captain, where necessary, kind of protect them from the rest of the healthcare system. And so that's a really key piece. One of the great primary care models that was referenced in that Hotspotters article, less than 2 hours from here, Camden, New Jersey. Some of you may have heard about the Camden Coalition. Dr. Jeff Brenner, he's a MacArthur Genius Grant winner. He makes some pretty hardcore points, pretty provocative. He basically says medicine is basically the Enlightenment bypass medicine. The Enlightenment was about rational thought, the scientific methods, self-critical thinking. And if you look at a lot of medical training, you're not rewarded as a resident to chime in and question stuff. He basically says most doctors really don't understand the scientific method or statistics. And some of these are about really giving people the tools. I think some of these health plans will codify that. And also, in the case of Lown Institute, they are very focused in on overtreatment. And there's pretty rough examples that aren't these massive outliers. I mean, one of the ones that really stuck out with me in terms of the overtreatment was this description of this woman in Ohio, 52 years old, had started a new workout program. And basically thought she'd pulled a muscle, but wanted to be careful, so went to the ER. The ER doc thought, yeah, it's probably a pulled muscle, but why don't we take a CT scan, and take a look at what's going on here. As scans often do, there's always something there. And so they said, okay, well, let's send her to the cath lab where her aorta was perforated. And so then they had to do a graft. There was a rejection of that graft. And so in a few months later, from a pulled muscle, she had to have her heart replaced. I mean, that's brutal. And it's like, and they have stories like that that just go on and on. And so we need to expect better out of the healthcare system. And unfortunately, people are doing it. I think there's also great organizations that are essentially applying kind of a concierge model at the benefits level, because it's hard to navigate healthcare. Even those of us who are in it, we have a little bit of an advantage, where they help them navigate not just the bill, but where to go, and it turns out not just as a gatekeeper to keep them from doing stuff, but how to make decisions. One of the things I hear a lot from docs who are in the direct primary care, I coined this term called the nega claim, because it's kind of borrow a concept from energy conservation, the negawatt, and it's basically what amounts to a self-denial of a claim, where what you find is if patients are given information about the choices they have, which are often not, they tend to get railroaded, they will choose the less invasive approach as a starting point in almost all cases. And so it's a lot of that, and we certainly hear about shared decision making. So these programs, there's a startup called Zest Health, Quantum Health does a lot of stuff in this area, some great programs that really, again, all these have some terrific ROI, terrific results, and really the quadruple aim that I mentioned earlier. True price transparency, I would argue most of the so-called price transparency tools really just give you the best bad deal. Don't really look at the costs. And do some direct contracting at real cost. And so there's some really, really neat things that are going on there that are good for the practices, because they can avoid a lot of the nightmare they have to deal with claims and patient receivables for direct contracting, get paid right away. So that's an example. One of the last I'll highlight, particularly relevant here, is one of these great a good example of this, one of these great primary care models, an organization called ChenMed, Medicare Advantage, they play in the Medicaid space as well. They've not only woven pharmacy management into primary care, they've woven it in the exam room. So before an individual, normally the doc writes a script and, maybe it gets filled, maybe it doesn't, all those issues. They really use the sort of authority and relationship that the doctor has to initiate that relationship. So the pharmacy is basically in the exam room. And so they start the process there and really do a terrific, rigorous job there. And so that's a good example of that. There are many others that are in this kind of health Rosetta, but I thought those were the ones that were worth highlighting in the time we had here. Kind of final slide. A project that I'm working on with a guy named Leonard Kish. He's the one who kind of coined this phrase, patient engagement is the blockbuster drug of the century, and very astute guy. And basically what we've done is essentially curated what amount to a set of guiding principles. For some of you who have been around the internet for a while, we're not claiming to be the Clue Train Manifesto, but that was also very inspirational to us. That really, I thought, did a great job of laying out a set of guiding principles, but also was very prescient about where the internet was going to go, where it should go. They updated that fairly recently, and that's the idea. I'd say we're at version 0.8 right now. So if you Google 95 Theses for a New Health Ecosystem, you'll see it there. Would love the feedback. It's like the Health Rosetta, open source, so take it, rip it. And I would hope that organizations would take a look at that and measure their own programs like, hey, how are we stacking up against this? Because I do believe that will be a big driver of success in the future, is how well do organizations adhere to those principles. And so take a look at that. The more brutally honest feedback and input, the better. We've iterated a lot. Some great people have inputted, but we need to continue to crowdsource that. So looking forward to any questions that we have. So maybe a couple crowd questions and then.
Yeah, I think what we'll do for sake of time, I'm not going to do my formal Q&A.
Okay.
But I did have 2 targeted,
Yep.
and then we'll see if someone wants to win a hat. You had an article last year, IBM for